Ora
Okay.
si registrerà la conferenza.
Okay. So thank you. I want to introduce Conseil Shino, one of the best and most important professor in the world. He knows everything about ACL, and he has recently published a really interesting book, The Essence of Anterior Cruciate Ligament. It's a book that I suggest to everybody to read because it's very, very important and give us a lot of new information and a new view of the ACL and surgery around the ACL. So I start with the first question, Conseil. The book that you have recently published is a sort of summa of your scientific and professional life spent around a fascinating anatomic component of our knee, that is the ACL. At the end of this trip, in your opinion, still persists some mysteries around the ligament or not?
Still, we know something regarding ACL, something, but not everything, you know?
Yeah.
But just comment. I'm not ending this trip. Still, I'm alive, okay? So
Yeah.
I answer your question, okay? Our study clarified the structure of the ligament itself, insertion sites, including underlying bone, as well as biomechanical function under in vitro loads. However, we don't know yet how the ligament behaves during in vivo motions, including sports activities or walking or running or something. Some new innovative technologies are required to address this question. We are still students to learn.
Okay. Thanks a lot. So you said that for 20 years you have copied the American approach to look at the ACL and to treat it. Then you have changed your mind completely. So which elements have convinced you that the American way was not the correct or the correct way to look at this ligament?
In the beginning, you know, in the beginning of arthroscopy, two incision outside in ACL reconstruction technique was copied by myself, then followed by one incision transtibial technique. While the two incision procedures was acceptable in outcomes, but the other one incision one was not acceptable. Many patients were suffering from subsequent medial meniscus tears or residual instability. Even if they show negative Lachman postoperatively. Finally, I realized the reconstructed ACL was oriented more vertically than the normal ACL, resulting in insufficient function of the graft and graft PCL impingement. Therefore, I decided to go for the nature anatomy after quitting to copy American way. You understand me?
Yeah, absolutely. Absolutely. So that's why you changed completely your approach.
Right. Totally changed.
Okay. So depending more on the transtibial technique that was absolutely non-anatomical. That's why.
No. Very almost impossible to create an anatomical tunnel with transtibial technique.
Okay. And from the anatomical point of view, what are, in your opinion, the characteristics of the ACL that, based on your studies, are different from those described before? So there's a new anatomy of the ACL.
Okay. Yeah. You know, they say that we have to adore anatomy, not create anatomy. Okay, that's the kidding. But as you know, the ACL around femoral attachment area looks different between in extension and in flexion. You know,
Yeah.
people tend to observe the ligament around the femoral attachment area in flexion, while the functional position of the knee is in extension.
Yeah.
So to resolve this discrepancy, we conducted the histological study. It clarified not only the exact location of the insertion, but also characteristics of the enthesis and underlying bone.
Yeah.
We are
Okay.
surprised morphology of the insertion reflects the biomechanical function. Totally surprised.
Okay.
Big surprise.
But so Freddy Fu, for example, it was a little bit similar to your approach, or you think that also the Freddy Fu approach, so the American approach, still is different, still different?
I like Freddy. Freddy is different among Americans, you know.
Yeah.
But in his case, a little bit inconsistent in terms of tunnel location or something. Or sometimes, this tunnel very totally anatomic, but the other situation, no. So I don't follow him exactly, but but I like him. That's
Okay. Okay. Perfect. So from the clinical point of view, which are the tests that you consider the fundamental to diagnose an ACL injury? And what do you think about the ACL partial lesions? Are they real, or we can consider them fiction?
yeah. We have to live in reality or not in fiction, okay? But
Yeah,
I believe the most fundamental test should be a Lachman test.
Lachman.
Anterocruciate ligament functions to stabilize the knee in almost anterior direction, just a little bit anterolateral direction, okay? So the Lachman test is the most reliable test, and it makes possible to detect the very small amount of abnormal translation.
Okay.
If you do a pivot or something, then you could not detect a very small amount of translation of the tibia with relative to femur. You know, Lachman
Yeah.
test could detect subtle displacement, so more sensitive, I would say. Speaking of partial tears, I'm afraid all the injury diagnosed as partial lesions should be maybe total lesion. Even if some part of the ligament are continuous and looks intact, but the other part must be stretched to show abnormal laxity.
Okay.
So in acute cases, partial reconstruction for the disrupted portion may help the remaining stretched portion heal. However, in chronic cases, my choice is the anatomical reconstruction after excising the stumps.
Okay.
You should choose the most reliable way to pursue the best result for your patients. You know,
Yeah.
you have to love your patients, not destroy the patient's life. Okay?
Yeah. Okay. Great. What about imaging? In your diagnosis, is real important, or your diagnosis is more based on the clinical outcomes? And what do you think about the bone bruise? Do you consider them important or not?
You know, the imaging is very, very important in diagnosis of ACL tear, as well as in the evaluation of clinical outcomes. For evaluate clinical outcomes, you know, imaging. There's no bias. You know,
Yeah.
just machine takes the images. So there's no room for bias during a subjective evaluation or clinical evaluation or clinical exam or something. So in the past, when I was very young, you know, the American surgeons are always proud of their excellent results. Just they say they're totally stable. Patients are very happy and not a problem or something, including. So I read many American papers describing like that. But later on, we found that the publication was based on the biased evaluation by themselves. Okay, but imaging, there's no room for bias. So imaging is very, very important to evaluate the graft itself, as well as the status of the meniscus or something. But the Americans, they say, you know, MRI is not necessary. MRI means more radiologist income or something. We do surgery, so there's no need for MRI.
Yeah.
Famous American guy told me that way in the past.
Well,
you know.
So I understand.
Regarding bone bruise, you know, bone bruise means the evidence of impact loading, or in other words, it's a kind of incomplete fracture, depression fracture.
Okay.
But if it combined with real depression of the articular surface, some treatment may be required. But such cases are very few, I think. So, you know, fracture, a kind of insufficiency depression fracture, heal spontaneously. So articular surface irregularity may cause a problem, but if the articular surface is okay, no treatment is required. I think so.
Okay, thanks a lot. So talking about the treatment, when do you suggest sometimes a conservative treatment? So there are any indication for you for conservative treatment in an ACL injury?
Yes, conservative treatment is applied when the injured ligament shows continuity in MRI and Lachman sign is mild. So in that situation, I think that injured ligament have some potential to heal spontaneously. But if the ligament is totally ruptured and showing gross instability, then I would say there is no room for conservative treatment.
Okay.
Many people
So,
my opinion.
Okay. Do you agree with these new trends that push on the acute repair of an ACL injury if the lesion is on the femoral side, using, you know, an internal brace, so a synthetic augmentation or not?
It's a kind of arthrex procedure, right? Synthetic augmentation may help to mobilize the knee in the early post-operative phase. You know, primary repair itself does not allow us to mobilize so early, but it may cause stress shielding to bring adverse effect on tissue healing in the late phase. So it's a critical balance. But at the moment, I'm afraid the synthetic augmentation could be a game changer for acute ACL repair. you know, looking at the healing situation of the injured ligament, medial collateral ligament heals without adding any treatment.
Yeah.
You know,
Yeah.
first the scar tissues grows around the injured site, and then it go shrinking
Mm-hmm.
to to be matured as a ligament. But ACL, it it doesn't go such a process. It is a I would say hypertrophic process is very, very important to make a scar tissue get maturity. But in ACL situation, such a hyper so big scar tissues is not produced inside the knee joint. So the circumstances is different. So I would say the ACL repair has ACL repair has a not so is not so reliable option for
Okay.
acute ACL. It's my opinion. I'm not so totally sure.
Okay. But in the past, you're a long story about the ACL treatment. You ever repair the ACL at the beginning? 30, 40 years ago, someone was
Right, I
trying
did
to.
that. Yeah,
You
I
did
did
that,
that. Yeah.
and
So
you
yeah, some patients are okay, but if they are very low in terms of sports activity,
yeah.
but otherwise, other highly active patients not working.
Okay.
Furthermore,
Okay.
acute repair should be done in the acute phase. So there's a high risk of osteofibrosis.
Yeah. I agree with you. Absolutely.
So
And another question about the graft, choice of the graft. For in your experience, one graft fits all, or you choose different graft for each patient, depend on patient characteristics.
yeah, at the moment, I do believe BTB graft best.
Okay.
Strangely enough, it grows to mimic the normal ACL in the notch. As I told you before, 2 years ago or something, grows in the notch.
Yeah.
It's amazing. But I sometimes use hamstrings or quad tendon in case of BTB graft is not available or not suitable. For instance, multiple revision cases or anatomical variations or something like that. But I
Okay.
do believe BTB is the best at the moment.
Mm-hmm.
Bone plug on both ends, and so much easier to heal to the tunnel wall, and the graft grows to mimic the normal ACL. It's a amazing graft, I believe.
Okay, but you know that Zmiglievsky that has proposed the new a sort of similar to you. I don't say exactly the same anatomy of the ACL suggests the quadriceps tendon. Do you agree with that or not?
As far as I know, the guy uses the quad tendon without bone plugs, right?
Yeah.
So if you utilize soft tissue graft, then the pretension prior to the fixation, final fixation. And looking at the femoral tunnel, looking at the femoral tunnel aperture, the graft makes angle 110 degrees between the tunnel and the graft. That means graft bending angle. So if you tension the graft, then the graft deforms according to the direction of the force. So you have there will be the space behind the graft and in front of the posterior tunnel wall. That means graft moves while extension and flexion movement. So I would say I prefer bone plug attached graft, even if the quad tendon is utilized. Then there's no movement inside the femoral tunnel.
Okay. And many young surgeons will see this interview because it will be shown to all the participants of the to the meeting. So can you explain to a young surgeon what does it mean for Konsei Shino and ACL reconstruction, anatomical ACL reconstruction, the steps, the choice, because it's quite difficult to understand exactly what it means. And so, if you can explain easy to this young surgeon, what does it mean?
I'm not sure I could follow your question sufficiently, but you know, we surgeons should mimic the ACL by grafting as closely as possible. So if you are behind in terms of mimicking or you are not so good at mimicking the Mother Nature anatomy, then the graft functions will be not enough. So that means you have to hit you have to do the very precisely anatomical reconstruction for your patients. No, not this question is very tough to answer. But
I understand.
sorry about that. So anyhow, learn from the Mother Nature anatomy and copy the good surgeons and to brush up their own technique and to mimic the native ACL as closely as possible.
Oh, okay. I have two last questions. The first, what do you think about periphery? So there are, you know, that Professor Ferretti and many other surgeons in Europe propose a frequent reconstruction of the anterolateral ligament or reconstruction of the posterolateral corner. In your practice, are they effective? Are they necessary or not?
Good question. In the beginning, before arthroscopy years, I was very young. In that era, the extra-articular procedures are very popular, advocated mainly by American surgeons as well as European. But just extra-articular procedure didn't work to stabilize the knee or patients go back to sports. So I combined intra and extra-articular procedure. Then it was not so bad. But I feel the graft itself was very stable at that time. So I compared the procedure with extraarticular, without extraarticular. And I concluded that extraarticular procedure is not required if the intraarticular graft goes well. So I abandoned it many years ago. I would say the extraarticular procedure may be helpful if the patients are suffering from residual laxity due to incompetent ACL graft.
Okay.
If the anatomical graft functions to restore stability equivalent to normal knee, extraarticular procedure is not required anymore. That's my relief.
Okay.
Actually, some guys advocated to add extraarticular tenodesis to reduce re-injury. I'm afraid added periarticular restraints may cause some subtle stiffness to the knee, which may result in reduction of re-injury. But I'm not sure the added restraints are happy to patients or not.
Okay, thanks a lot. Very helpful in this for this question. So the last is about the rehabilitation. Have you changed your rehabilitation postoperatively using an anatomical ACL reconstruction? Is quite different, or is quite similar to those that proposed Shelburne or all these guys in the past?
Remember, my physiotherapist told me that currently the mobilize the knee is very easy compared to the past. Even if I utilize the very invasive BTB graft harvesting, BTB. So that means, if you put the graft in very precisely anatomical location, then the mobilizing the knee is very easy. So I have not special idea in terms of post-operative rehabilitation at this moment.
Yeah.
But just one thing I have to emphasize is to control the tibial slope during a few months after the reconstruction. In the early remodeling phase for the graft, it should be attenuated because it's a situation of ischemic necrosis.
Yeah.
Therefore, care must be taken to keep anterior inclination of the tibial slope to protect the graft while weight bearing. It could avoid early failure or stretch out of the graft. This is my advice.
Okay.
Regarding the timing of return to play, our MRI studies suggest it takes a few years for graft maturity.
Yeah, that's true.
However, I believe not a single patient can wait for such a long time to go back to play sports. Not a single patient. So in reality, our patients go back to sports around 8 to 9 months.
Okay. But you talk about, that's the last phase out of the question, really the last one. You talk about the tibial slope, and that in Europe, some surgeon correct the tibial slope if it's too excessive, associating this to the ACL reconstruction. What do you think about this way of manage a chronic ACL deficiency?
Quite honestly, I have no experience on slope reducing osteotomy. But remember, if you do slope reducing osteotomy, the knee shows hyperextension. So I would say not a single patient prefer the imbalance in terms of hyperextension between sides. Very strange. But they say it's okay. But I'm not sure. What about you? You did some?
No, never, never. Because I know you know that I'm quite scared about that. So I never did it. But you know,
I'm afraid about.
there are
I'm
people.
balanced knee. I'm
Yeah.
balanced knee. Okay.
But there are
One
some
is
certain
one is
issues.
normal. Oh, very strange. Okay.
Yeah. Absolutely. So I want to thank you very much. You are at the end of this interview, and was very interesting. I want to suggest to everybody to buy your book, which is very new, and has everything about the ACL, everything about you have studied. I hope that in next 10 years you will produce another book
Oh,
with
oh,
news, more
oh,
news about the
oh,
ACL.
oh, oh. You are killing at me or killing at me.
No. You said at the beginning that you are still there and you want to know more about the ACL. So
But
if you know more, you have to give us all your information and new information about it, because it's very.
oh, 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 tough suggestion. Too tough. Yeah. But as
So
far as uh, my lifetime allows me to live, I will continue to learn something.
you have to, Conseil. You are so important to the scientific world, and so I very much we wait for you for your new knowledge, new things to that you will say us. Okay, so that's great. So I want to say hello. I want to thank you from all the Italian people that will see your interview, and we have a lot of new information and scientific information from you. So thanks a lot, and I hope to see you in Italy, in Milan, at the ESCA meeting. So thank you for your time, Conseil. It was a great honor for me to interview you.
Thank you so much for the opportunity for me to participate in your coming Congress. Yeah, my friend Massimo, thank you. Grazie.
Thanks a lot. Thanks a lot. Say hello
Okay.
to all the Japanese guys, and we know that the two fellow will come in Japan this year, and so I hope that everything goes good.
Okay. Very good. Very good.
Bye,
Okay.
Thank you.
Ciao. Ciao.
Thank you. Ciao,
Thank
ciao.
you.